Hi, this is Brian Wormers. I'm recording a lecture on peripheral vascular disease. These are some of our learning objectives, talking about, assessing of vascular disease. We're going to talk about risk factors related to vascular disease. We'll talk about atrial and venous vascular problems. We're going to talk about diagnostic testing for peripheral vascular disease. We'll talk about patients with peripheral vascular disease. We're going to talk about some nursing interventions for those with vascular disease, and then we'll talk about Raynaud's and Brugger's disease. So as an overview, you need blood throughout all your whole body. This includes your periphery, and so we have arteries and veins that work on that. No, that's a huge surprise to you. What we do find, though, is that legs are more impacted than arms are, generally speaking. And generally speaking, when we say peripheral or vascular disease, it implies arterial disease, although it could be venous on occasion. One of the main causes for this is atherosclerosis. Some of the other risk factors can be hypertension, hyperlipidemia, diabetes mellitus, smoking, obesity, cholesterol, and a family history of it. So, if patients have this and they've got peripheral artery disease, and they've got a higher risk for angina, MIs, and stroke. So with PVD, often it's asymptomatic. No issues, no claudication, which is the pain in the calf that you feel. No decrease in pulses. Stage 2, you get claudication. So when they work out and they exercise or they're doing something strenuous, then they feel that leg pain in their calf. And it goes away, and it comes back with exercise. Stage 3, when they're resting, then they have pain at rest. And then 4 is when they've got it severe enough where they're getting necrosis and gangrene and ulcers. So as we kind of talked about some of these risk factors before, we're assessing for these. So age, ethnicity, family history, diet, drugs, exercise, smoking, as well as medical history, including hypertension, kidney disease, cardiac disease, medications, and diabetes. All these can play a factor in your perfusion. So objective, most often there's no symptoms like we said before, but as it progresses they're going to get claudication as well as leg pain and ulcerations. Other things that can happen with this one, headaches, and you're going to see retinal changes with this, and maybe even some renal artery stenosis and abdominal bruit from that. So lots of different things could be going on here as we're talking about this. So intermittent claudication is one of the big things with this. We talked about that before. Peripheral pulses, so checking the feet and making sure pulses are equal and strong bilaterally, at least a 2+. And then of course looking for any ulcerations. So magnetic resonance, angiography, so you're looking at the blood flow in these peripheral arteries and you can see how much flow that they're having. You can do blood pressure assessment with this, so you're looking at your ankle brachial index. So you take your ankle blood pressure divided by your brachial blood pressure, and if it's less than 0.9%, then you have that diagnosis of a PVD. So what do we do with this? So of course, if we can do exercising and positioning to enhance that circulation, we will. We're going to try and promote vasodilatation. You can apply some heat. Try to avoid stress, try to avoid nicotine, anything that's going to have a vasoconstrictive effect with this. We might thin the blood a little bit, so using your aspirin, depending on your doctor, if they want 325 milligrams or 81 milligrams, or some Plavix to try and thin that blood out a little bit. And then of course we want to minimize the blood pressure or hypertension, so we will administer blood medications to keep blood pressure controlled. So non-invasive, non-surgical, so you can do percutaneous vascular interventions. So you'll anticoagulant and then do this through the skin and try and intervene it that way. Otherwise you can do more of a surgical management with revascularization with a bypass. What you're going to see after that, or what you could see, would be graft occlusion. So if you're putting graft material in there, that can clog off. Otherwise bleeding. Lack of pulses, clots, different things like that could be a major issue. Intervention-wise, so home health care and self-management. So try to vasodilate as much as possible, warm environment, elevate, avoid that vasoconstriction. Be very careful with foot care and leg care to try and prevent any ulcers or injuries from occurring. And of course, exercise, nutritional counseling, drug therapy as prescribed. So you can get an acute form of this with embolism, and so that could be caused from a couple of different things, but could be following an MI or AFib. So you're going to see pain, pallor, pulselessness, paresthesia. So all your five P's of pain related to CMS. So make sure that you're watching for those things. I know that there's a sixth one out there. If you've learned that, that's great. But pain, pallor, pulselessness, paresthesia, paralysis, and poikilotherapy, changes in temperature are major parts of this. So treatment-wise, anticoagulation, so if you can break that clot up, that's a big thing that we'll do. Can get aneurysms. Aneurysms can impact the body. We want to know if it is fusiform or secular. So secular is an outpouching of a little sac. Fusiform is kind of around the whole vasculature. This is often related to hypertension, atherosclerosis, smoking, age, gender, family history. You have your AAAs that can account for most aneurysms. So that's your abdominal aneurysm. So usually they're asymptomatic until they rupture, and then it's a big deal. So most patients have no complaints until it ruptures and they start getting this gnawing abdominal pain, flank pain. So you might actually even feel a pulsation in the abdomen. You might hear a bruit. If you are hearing a bruit on this one, don't push on it. You don't want to be palpating on this and actually push it until it breaks. If it breaks and you get rupture, that's going to be a very critically ill patient. It is amazing how much blood that one can lose through this, and it's a very quick type of situation. So diagnostic-wise, what do we do? So we can do a CT to assess the size and location of this. We can do an echo, once again, to look at the size and location of this, and we can do an ECG looking at implications for a cardiac. So other interventions, we're going to check blood pressures, trying to minimize hypertension. We're going to check pulses, making sure we get good flow. We're going to have looking at circulatory checks. So maintain that blood pressure and decrease it, usually trying to prevent hypertension is what this one means. Surgical management, so elective versus emergent, you can figure that one out. Elective, of course, is going to be a lot better. Emergent is, as it says, emergent, and it usually is a much more rushed and more life-threatening event. So, can do grafts and stents with this kind of situation. If there are any embolisms, you can remove those. And then post-op, definitely activity restrictions with this, trying to decrease hypertension and stress on this while it heals. Peripheral venous disease, so DVTs are common with this, or are common in people. So what are you going to see with the DVT? Within this, you're going to, one of the main things that can cause DVT are Virchow's triad. And what that is increased stasis, so, blood's kind of pooling. You got endothelial injury, and then hypercoagulability. So this is common in post-op patients, especially at the hip, knee, and prostate. People that are on contraceptives, people that have heart failure or cancer or immobility or an increased age. So what do we do with this one? Well, of course, trying to prevent it. Trying to get people up and active as much as possible. Avoid dehydration. Keep them exercising. Watching oral contraceptives because that has an increased risk for our DVTs. So if they are high risk, you might do a lot of patient education, leg exercises, early ambulation, definitely keeping them hydrated, compression stockings, SCDs, and anticoagulant therapy. So how are you going to know about this one? Well, signs and symptoms is calf, groin, tenderness, depending on where that clot's at and what's it obstructing. pain. It's kind of usually a sudden onset. It's usually unilateral. It's usually not a bilateral type of situation. Pain with dorsiflex. This is called Hogan sign, but this is an unreliable sign. If you got it, great. It's not something I'd be stressing about because it's a small percentage. So objective. So you're looking at that limb. Is it warmth? Is it red? Is it ruddy? Diagnostic-wise, venous Doppler is your go-to with this one. So you're looking at the flow using ultrasound and seeing where that's at. You can do a D-dimer looking for inflammation, and it's a risk for clotting. So that's, of course, something that would be valuable with that. Planning and implementation. So you're looking for things like thrombus formation, increased size of DVT, non-surgical management, so you're going to rest it. No massages to that. That's an important aspect of this. They can ambulate, and you're going to start them on drug therapy. So, that's your low molecular weight heparin, like your Lovenox, maybe warfarin, heparin, those kind of things. This is where they have that bridging. So you have the unfractionated heparin, and then you follow by warfarin. And once that warfarin and / Coumadin gets up to therapeutic levels, then you're weaning down the heparin of that. Surgical management, you can go in there and remove it. You can use balloon angioplasty, where they thread up through the vasculature, inflate a balloon, and open things that way. And then sometimes after the balloon, they'll put a stent in there. And so that's kind of a mesh type of situation to keep it open and give it structure. So non-surgical management of this, so drug compliance, make sure that they're taking their medications when they're supposed to. Good dietary so that they can heal. Follow-up monitoring as recommended by the providers. And then, given these information about interactions, adverse reactions with meds and with their devices, if they have anything implanted in them. So venous insufficiency. So this is valvular damage caused by standing, sitting, obesity, thrombus. So this is going to look like they've got lower extremity pain, usually a lot of edema with that, and you're going to see like a stasis dermatitis, so redness, itching. You're going to see ulcerations. So with this one, stasis ulcers are pretty pathognomonic with this irregular borders, but it's on the medial malleolus, so it's on the inside ankle bone. And if you're starting to see that, that's really, indicative of this type of venous insufficiency. Tends to be chronic and difficult to heal, which is not much fun. So diagnostic-wise, if we're seeing these kind of things objectively and subjectively that we kind of know, but of course we can do more things with like ultrasound and looking at the perfusion that way. So what do we do? So compression stockings, SCDs, wound care, especially if they've got those ulcerations on their ankles. Skin care is a big thing, trying to prevent that wound care. Exercise, diet, weight restriction often is the case with this one. Medications, antibiotics for any of those open wounds and ulcerations so they don't get septic. Antiplatelets to try and break up any clots in there and get good perfusion, and steroids to try and decrease any inflammation. Surgically, we can do ablation, so we can, destroy some of these, and we can use sclerotherapy, trying to narrow down some of this vasculature. That might be too big. And on our final slide here, we're going to be talking about Raynaud's disease versus Berger's disease. And so you can see the two are honestly very similar. You're going to have acute inflammation, thrombosis in the arteries and veins and feet, versus this is more of a vasoconstriction. So this isn't really thrombosis. This is just kind of a natural event, cold or stress. And you're going to see this sometimes listed as a phenomenon instead of a disease. So this one tends to be more triggered by cigarette smoking. This one can be, but the cause is really kind of unknown with this one. So this one could be a connective tissue or autoimmune disease tied to Raynaud's. But either way, what you're kind of seeing is with this one, the distal extremities get white, blue, and then red as circulation kind of returns. They get numb. It's painful. And Uncommonly, they can get ulcerations or develop gangrene in the finger pads as that circulation clamps down. This one's more in hands and feet, and you get very similar signs and symptoms of this one. And then this one, you can get ulceration or gangrene as well. Big treatment for this one, smoking cessation. This one is using smoking cessation. But then when you're in a cold environment, using mittens rather than gloves, especially like if they're shopping in the freezer section or if they're living in South Dakota and it's cold outside. They should also try to avoid stress and avoid sudden changes in temperature. So, all right, that concludes this lecture for peripheral venous disease. If you have any questions, please contact me.